the it is good morning or good afternoon. We are here with a very day-to-day topic of joint pains in younger patient. So, what is the younger patient group? That is teens to 40 years of age. This is the common population we come across, and they are very active, they are very energetic, and they are more, they want more better treatment, and they are more informative, and they can't wait for like old people that somebody will come and take them to the doctor. They are more innovative, and why it is important? Because early diagnosis is very crucial to prevent chronic damage to the joints. So let's find out what are the common causes we come across the joint pains. Definitely, the younger people are more active and they take in all types of sports, daily activities, and musical plus dancing and so many other activities, and they come across various overuse and physical strains of throughout their younger age. These strains can lead to sprains, strains, tendinitis, or bursitis. Now, let's be very clear about the definition of a sprain. Sprain means injury to the ligament, just like ankle sprain or wrist sprain or elbow sprain, knee sprain. They involve the ligaments, the main ligaments, which can be one or multiple. Then what is strain? Strain means when the muscle is pulled up because of overuse or because of overstretching of the muscle. It can be one of the muscles or group of muscles which can be involved. For example, in sprain, ankle sprain, we have the medial collateral ligament, lateral collateral ligament. In the knee, we have the medial collateral ligament, lateral collateral ligament, anterior cruciate ligament, posterior cruciate ligament, and in the hips we have the different ligaments plus the wrist. We have the dorsal wrist, ankle, dorsal ligaments. So many ligaments. Every joints have multiple ligaments. Similar is with the shoulders. So it depends on the physical activity or sports activity. Say athletes, they have mainly involvement of the foot, ankle, knee, or hips. These tennis players or the badminton players or the squash players, they will come across shoulder, elbow, or the wrist. Similarly, the wrestlers, they or the boxers, they will come across different types of sprains depending involvement of the different this thing. In cricket, for example, the fast bowler will have lot of issues with the shoulder, which have multiple ligaments and the cuffs, rotator cuff is there. The strain, the muscle strain. Say athletes, when they are running long distance runners, they can have hamstring strain, which they can have the Achilles, tendo-Achilles strain, or they can have the other muscles of the back or the hip, muscles around the hip, abductors or adductors strains. Similarly, the tendinitis, when the inflammation of the tendon is there, so the muscles, when they get attached to the shoulder joint, they get attached through the tendon. We have the rotator tendons, which include the supraspinatus, infraspinatus, subscapularis, then the tendo-Achilles, then the hamstrings are there, semitendinosus, semimembranosus, so many are there. And nature has provided to cushioning, that's called the bursa. We have so many bursas in the body, depending to prevent any inflammation, any injury. And if they get overuse can lead to inflammation of the bursa, which is called bursitis. The bursa can be around the trochanter or around the ischium, around the biceps, fibular neck, uh, biceps, bursa. That's around the shoulder. There are so many elbows. There are so many bursas which help to contain the shock. They are there to prevent the shock, which we strain
No, no,
achieve.
no, 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 no.
Pardon? So these are the various which are the most common in the younger people. They are because they are more active. Then the other group we have sedentary people. They are the young people. Definitely, they are the main population which is working in the offices on the I mean laptops, on the computers, on so many other this thing. They have a very sedentary lifestyle. They are sitting. Their posture is similar, looking into the. And these days, there people are there who are looking on the screen 2 hours, 3 hours, even on the mobile phone, which leads to stiffness of the neck and the dorsal spine, and even the lumbar spine. And the sitting there, it leads to change in posture. That is, it causes unusual strain on the anti-gravity muscles of the neck or the dorsal spine. They get weak and they become stressed out and they become painful. And these are the commonest uh, sedentary lifestyles. And the sedentary lifestyles again leads to overweight, obesity, and obesity, is a big issue worldwide. And India, we are also now observing that people are becoming rich. They are spending less, more on, fast food, and they have less time, and they are having obesity issues. Now, instead of initial obesity was a no in India. Now around 30% of there was a recent survey that 30% of youngsters are now obese with BMI of more than 30. Another important cause is the autoimmune or inflammatory conditions. The joints we have rheumatoid arthritis, the ankylosing spondylitis, then the hypothyroid and the juvenile diabetes. In rheumatoid arthritis, because it's an autoimmune disease, there are changes in the inflammation and leading to swelling and redness and difficulty in joint movements, which can cause weakening of the muscles surrounding the joint, and there is always swelling which patient is not morning stiffness, which is patient is not comfortable throughout the day. And they have different stages. It can be passive stage, active stage, early stage, or advanced stage. In the early stages, because of the uh, spasm of the muscles, they can develop all kind of deformities in the joints later on. And moreover, they are not able to utilize their joints fully. They're not 100% mobile like other young people, and which causes, in the long run, weakness of the bones, which can be initial osteoporosis. Plus, many of them in rheumatoid and ankylosing, they are on steroids, which leads to weakening of the bones. And this is called steroid-induced osteopenia or osteoporosis. And so it is a vicious cycle which is causing multiple problems with these people. Add on the underlying nutrition deficiency. If you come across the survey worldwide, the vitamin D is deficient in more than 90% of the population worldwide. And why so? Because most of our food lacks vitamin D. And I don't think most of the people are uh, moving out, although the sun is a precursor for vitamin D initiation of the uh, cold calciferol under the skin, which leads to the reaction which leads to production of the vitamin D. But instead of waiting for that vitamin D, one should be well versed, and one should be taking either vitamin D in the form of dietary products or non-veg products, including fish and all, so many other uh, non-vegetarian which are rich in vitamin D. And if need be, we can go for medicines, intake of vitamin D syrups or capsules or pouch are there also. And for the better involved absorption of vitamin D, we need calcium. A regular daily calcium intake of minimum of 200 to 400 IU is important to maintain good levels of calcium and vitamin D in the body and the bone mass, bone stock added on with magnesium. Magnesium is another one thing which helps to prevent muscle cramps, which is very common when the calcium and magnesium are on the lower side. And many young people will come, they will complain that they have a lot of cramps in the night or while they are sleeping, and which leads to, I mean, lack of interest or lack of activity. And if one is taking care of the dietary deficiencies, stressing on the vitamin D, calcium, and magnesium, so it will take good care of your musculoskeletal system. That is the muscles and the joints and the bones. This has to be supplemented with good protein diet. I mean, a diet containing of around 15% or 20% of the total diet with protein is sufficient to maintain your muscle mass, to maintain your bone stock, and prevent daily body pains, joint pains, and lack of activity and lack of interest in your daily activities. As such, most of the patient will complain of stiffness, will complain of swelling, warmth, redness, or persistent pain, reducing range of motion, and will complain of joint pains with fatigue. Now, this is how to manage. One is important is lifestyle adjustments. Instead of taking high activity or high velocity or high uh, impact sports, one can have, if one is prone to high injury to high impact sports or high impact activities, then one should be regular with low impact exercises. Low impact exercises, they involve toning of the muscles, and so that with minimum of injury to them. These are similar type of yoga exercises which take care of every muscle of your body, especially the limbs, and make you mobile. And this is very important in inflammatory conditions also. That's why we stress, instead of going for uh, a short period of exercise, which is happening. You see these days people are more interested in gym exercises, which causes more harm than good. I always prefer my patients to go for low impact exercises, which will keep your body toned up, with your spine toned up, the muscle mass toned up, so that you can have your comfortable life. Physiotherapy. The different physiotherapy modules include ultrasonic therapy, shortwave diathermy, interferential diathermy, and TENS. Now, in a brief, I will explain where does you need an ultrasonic therapy. Ultrasonic therapy are sound waves which penetrate very low. It means they don't penetrate deep, less than 5 centimeter, and they help in improving the vascularity of the area, and so that the pain substance is washed out. So ultrasonic therapy is very good for certain conditions that include which are superficial, say elbow or wrist or shoulder, a foot, sometimes ankle also. Now, how coming to the shortwave diathermy? Shortwave diathermy involves electromagnetic waves which penetrate beyond 5 centimeter. I mean, they are meant to help in healing of of the tissues which are torn, the muscles which are torn, that will can be around the back or around the hips or around the thigh. They are very effective there because they help in healing of the torn muscles and prevent any fibrosis, so that fibrosis is not formed, so that they don't become weak and they don't develop any kind of deformity. Similar is the interferential therapy. Interferential therapy is also for uh, healing beyond 5 centimeter, and there are different types of waves, and they again help in healing of the torn fibers, torn muscles, and even deep ligaments also of the around the hip or the facet joints or around the SI joints. It is meant. Then we have the TENS, trans-electric nerve stimulation. The principle of trans TENS is that it helps in relieving the neurogenic pains. How? By the old principle of gate control theory. Means they tend to block the nerve the nerves which are causing pain. They tend to block it, and they pass the alternative current so that the healing of the nerves cells is better. The other treatments, medical treatments, will definitely include non-steroid anti-inflammatory drugs. We have different types, and depending on the pattern you are comfortable, and depending on the suitability to the patient, depending on any history of any allergies to the any of the groups, we can give for a short time. Say I usually prefer for 2 to 3 weeks of anti-inflammatory depending on the patient's response, and I always tell them you can keep on reducing it as per as your demand of the body. Then we have the nutraceuticals. We have now so many nutraceuticals because coming to the nutraceuticals, we have various collagens which help in. Then we have boswellia. Then we have alpha lephalin. So many chemicals are there. There are natural nutraceuticals which help in muscle healing, which help in ligament healing, which help in articular cartilage healing. It depends on all those conditions. So we have different collagens. Say we have collagen 2. Collagen 2, which is usually taken from the bone, chicken bone marrow, or we have the fish uh, source also. This helps in healing of the articular cartilage. It helps in replacement of the articular cartilage. And if the patient is developing articular loss of up to stage 1 or stage 2, or and some cases of stage 3, it definitely helps in replacement of that collagen. Uh, then we have the type 1 and type 3 collagen. Type 1 and type 3 collagen is good for the ligaments because ligaments are rich in collagen 1 and 3. Articular cartilage is rich in collagen 2. So these help in their self multiplication. They make them healthy and they help them to recover them. Then, depending on the third, is the DMARDs. DMARDs are the disease modifying anti-rheumatic drugs. We have the different groups. Depending on, we have the primary DMARDs, and now we have the presently the synthetic DMARDs, which are required in rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and sometimes even in I gave in sometimes with the seronegative arthritis also, where the blood tests show nothing. I gave it for some time to wave off the weak immunity and so that um, the body starts improving. Now coming to the steroid injections, when to give? What is the role of steroid? The steroids will be two. One is the triamcinolone, one is the methylprednisolone, and where to give? Uh, Earlier, I used to give methylprednisolone in bigger joints, that is the knee and the shoulder, and the triamcinolone in the smaller joints. Now, there was a research some 2 3 years back uh, that even triamcinolone is effective in the bigger joints also. So I am now trying to shift to maximum triamcinolone. And when to give? Say, patient has an I've been a tennis elbow. Patient has come with the OPD and you have labeled it as tennis elbow. And the patient has sustained injuries, I mean, 2 3 days or within a week, less than a week. I will not prefer to give straight away steroid. I'll wait for the conservative treatment. That will include cold packs, a tennis elbow band, and physiotherapy. The physiotherapy will definitely include ultrasonic or tense therapy with elbow eccentric exercises to strengthen up the ERCB, extensor radialis brevis minor. Then I'll wait till maximum 6 weeks. However, if the pain is increasing without any response to the NSAIDs or without the conservative treatment, even after 3 weeks, then I will prefer to give steroid because it has the role of anti-inflammatory. Because the other anti-inflammatories are falling less or they are not working, then we should add on. And say after 6 weeks, what we should patient after when we label it as chronic tennis elbow till 6 weeks, or we wait till with the steroids with all this thing, and even if it is persisting, the pain is persisting, say after 3 months, then we label as chronic tennis elbow. Then the line of treatment changes. Then we have to consider something else because it is not the inflammation and the inflammation is not there. The healing of the ERCB, extensor carpi brevis muscle, is not healing, and patient has weakness in the all the activity. Then we think of regenerative therapies. What are the regenerative therapies we have? We have PRP or the platelet-rich plasma, or the GFC, not GRC, GFC, growth factor concentrate. We started with PRP, which has been given for, I think, for more than a decade. It has been there in the horizon. But no, now for the few years, we have GFC, growth factor concentrate, which is definitely a next generation of PRP without the platelets. What we wanted from the PRP was the growth factors, and now we have the kit which provides GFC, and you can give the injection of GFC in the ligament or in the muscle to in the tendon, so that the healing is there for the partially torn or completely torn. If it is completely torn, then the theory is different. Then the approach is maybe surgical. But if it is partial tear or uh, partial healing, then we can promote the healing by with the help of either PRP or GFC. PRP injection is more painful, and because of the platelet, we have to give many injections. We have in the duration of injection is 5 or 6 we have to give, and I prefer giving a gap of 2 weeks between the injections, but they are more painful as compared to GFC. Coming to the GFC, where we have the main crust, the growth factors which are important for the healing. Usually, I have observed that 3 4 injections in most of the conditions hold good. The duration I usually give is gap of 2 weeks, so to promote the healing and to get the maximum out of it. And definitely, if after 4 6 months the thing is not improving, say for with the help of this also, but before getting it, the putting on the GFC and all those, in some conditions, say like chronic ankle sprain, where you expect that anterior ATFL, anterior tibiofibular ligament, is weak clinically also. On your clinical examination, you may get an MRI done and find out whether there is complete tear or it's a partial tear. By with the help of, so don't hold back the MRI. When you are in doubt, always get the MRI for the betterment of the patient, that they will completely label it whether it is complete tear. If it is complete tear, then you have to do ATFL reconstruction or the reconstruction, ligament reconstruction elsewhere. And if it is only partial tear, then you can definitely consider the PRP or the GFC depending on the availability in your center. Now, I'm open to uh, discussion from various doctors, and there I would like to hear from their interesting about their interesting cases and how they manage it. With yes,
Uh,
Varun.
Sir, we have a question like the patient case that Dr. Filmona wants to discuss with you. So it's a 35-year-old male patient who presented with a CC of bilateral shoulder pain of 6 months duration, which once worsened over the past 1 month with limitation
Pain
of
was there
with limitation in the range of the movement, sir.
of the shoulder.
Uh, uh, he's not written. Dr. Filmona, can you unmute yourself and discuss with Dr. Rakesh directly? That will be better. But
Yeah, so you are right. It's the shoulder, bilateral shoulder pain for the past 6 months.
Right, right.
Yeah.
What is the age of the patient?
Sorry?
30,
35,
30,
yeah.
35. And is I don't think he must be an athlete or something like. Is the patient a known case of diabetes or other inflammatory conditions? No. Any history of diabetes in the family, or his sugars are okay, not taking any medicine for the. So if the patient with both shoulders complaints of difficulty in lifting of the shoulders, one thing is whether ask for the history of diabetes or thyroid. In patients of diabetes or thyroid, these problem is very common. Around, I would say 30% of patients my I get my practice, they have this. I always first ask whether you have taking any medicine for type sugar or diabetes or thyroid. If no, then I'll how that is how I approach. Then I will say whether you are doing any manual work or lifting some other activity which is involving heavy use of your shoulders. If they no, is okay. Then I'll get the plain X-rays done. What I will see in the X-rays, I'll rule out any joint space diminution. One thing, I'll rule out any calcinosis, any calcium deposits, which is another one of the causes which has to be ruled out. That is called calcinosis or calcification of the tendons. Then, if that is okay, then I will put him on the physiotherapy, which involves ultrasonic tense and shoulder exercises, and give uh, I mean a a prescription for anti-inflammatory for 3 weeks and ultrasonic tense cold packs, and look for how he responds. If he is not responding within 3 weeks, then I will get an ultrasound of the shoulders done. Ultrasound of the shoulders clearly reveals whether there is subacromial bursa involvement, which is impinging on the uh, this thing shoulder, which we call it impingement syndrome, sir, which is very common. Subacromial bursa, inflammation of the bursa, and the ultrasound will also rule out any partial tear or tendinitis of the supraspinatus or infraspinatus. I
Sir,
I
Dr.
hope
Mona has shared some additional information. Can I share it with you about this case?
yes, yes.
So, sir, his rheumatoid, LX rheumatoid factor is positive, ANA is
Oh,
negative, uric acid is
mhm,
normal, and MRI
mhm.
bursal sided partial thickness, tear likely, chronic of the right and left supraspinatus tendon at the footprint with associated subacromial bursitis.
Versa. So here we come. Positive history of rheumatoid with inflammation of the joints and inflammation of the bursa. So how we do this? One is the anti-inflammatory drugs, one is the anti-rheumatoid drugs, and give an injection of steroid in the bursa. and physiotherapy. This should take care of the inflammation. He may be needing but steroid injection don't repeat before 3 months. Wait 3 months plus. Patient should respond with injection of triamcinolone intra-articular in the bursa, right? And if that is not responding, then we have to go for scopy of the shoulder, where we debride the bursa completely and we look for the AC joint involvement and we look for the any tear in the supraspinatus or infraspinatus.
Hi, Dr. Filmona. Yes, Dr. Rakesh has just shared the treatment approach for this case. I mean, after the master class, like in the coming couple of days when we share the transcripts with you, we'll pick the relevant section. He has mentioned the name of the steroid also, and like if nothing works, final arthroscopy is also a consideration. Additionally, how we can help you is if you share detailed reports and your detailed note on the group with us, we can additionally share with Dr. Rakesh, and he may guide further. Dr. Filmona, does that work for you?
Thank you. Sure. Yeah. Thank you very much.
Right.
Sir,
Welcome.
we have a question from Dr. Paul, MD. So first is thanking you for the presentation. And his question is, must all cases start with medical treatments before progressing to regenerative therapies?
Yes. Initially, ask for the duration of the problem. If from the duration of the problem you find it is chronic, I label it 3 months. 6 to 12 weeks is the chronicity. Patient has been, when the patient comes to me, most of them have attended many consultants, and many of them come beyond 6 weeks. They have taken all types of treatment. That this means it is chronic. And if you do all tests which rule out any acute inflammation, you go for the regenerative therapy. If the patient comes initially, then you start with the NSAIDs. You don't start with the regenerative. Only 6 to 12 weeks, between the period of 6 to 12 weeks, and that even if the steroid has failed to reduce the inflammation, then you consider regenerative therapies. Ideal will be 3 months.
Okay. So now we have question from Dr. William Gataga. Dr. William is from Zimbabwe. How is the PRP
Yes.
prepared?
How is the?
PRP prepared.
Yes, we have a kit. We have a centrifuge machine. We take the patients around uh, uh, 10 to 14 ml of blood. We collect in a vial provided by the kit persons. We have companies which provide the kit. They have the heparin which separate the blood. They centrifuge it for some time, and then they prepare the solution, and then we inject it. We inject it all around the tendon or around the ligament. It is not like that if you take it and you give it around 4 to 5 ml of the PRP is available. Once we take out of the 14 ml or 12 to 14 ml of blood, we are able to achieve around 5 ml of the solution, PRP solution, and it should be given multiple pricks, not at one area, to achieve the maximum results.
So now we have a question from Dr. Ivan Ipavu. He is from Uganda. So how
Yes.
does plaquetic plasma PRP promote healing at the cellular level? Here's two questions. This is the first question.
Yeah. They have the platelets. They promote healing at the cellular level with the help of growth factors which they have. It is the growth factors. Different growth factors are there which help uh, in the healing of the ligament or the tendon.
Okay, so
They promote.
interestingly, his follow-up question is around growth factors only. So the question
Uh,
is, what growth factors are involved in PRP? Example, PDGF, TGF beta,
so
and what are
these
their
these
roles?
are the these are the various growth factors. There are multiple, and because it is more of a microbial issue, I'm not much in that. I'm more on in the technique and the how to apply and to get the achieve the maximum results. Right? There are so many because there are so many enzymes which help in the vascularization, and there are many enzymes which help in the regeneration of the cells. These are the various theories, TGP and all those VGP, and because one increases the vascularity and the other increases the cellular activity. That is the principle.
Okay. Now, sir, we have two questions from Dr. Onana Paul. Dr. Onana Paul is also country coordinator of Jivo in Nigeria. So his
Yes.
question is, what are your recommended nutraceuticals that are effective for joint pain treatment?
Yeah. Uh, if it is involving the articular cartilage, I will prefer giving collagen 2. There are many professionals available collagen with aflapin, boswellia, and there are many other uh, chemicals which help in promotion of the cell at the cellular level and multiplication of the articular cartilage and making it grow and make it much healthy. And the thing is, you have to give it for long, long time. And then we have the collagen 1 and 3 now, which is available separately from the collagen 2, which is helps in partial tear of the ligaments and the tendons because ligaments and tendons are rich in collagen 1 and 3. So many preparations are now available which help in separately giving these preparations.
Sir, now another question is, what are the alternatives for a patient who has been on joint pain analgesics, bearing in mind the problems with long-term use of most of these drugs, analgesics?
Mhm. See, is it? I mean, excellent question because you can't give the analgesics, keep on giving it like that because you have to identify it when to tell the patient go for surgery or take keep on taking analgesic because analgesics have their own side effects. They are more I mean, they can have cardiovascular issues. They can have kidney issues. They can have GI issues. These are the various uh, analgesics which have been causing trouble throughout. Just like say, ibuprofen, all those had lot of GI issues and nephro issues. They are more nephrotoxic, and ideally I give it for maximum of 3 weeks. I tell them you can reduce the full dose after 2 weeks if you are more than 50% better. And after that, I tell them maximum which they can have is paracetamol or combination of tramadol with paracetamol, which is available here, and that is safe for the kidney and that is safe for the cardiac and GI. If I don't prefer giving other groups more than 3 weeks. And if the patient is not responding and you find that the patient will benefit from the surgical uh, approach, you can recommend that.
Okay. Sir, I have because I was going, when you were presenting, even as a non-doctor, I could relate to a lot of parts where, you had mentioned about, low impact exercise, etc. And I want
Yeah.
to take your thoughts because I know your experience you have extensive experience in sports medicine and injuries also. So these days there is like a lot of thought on internet that exists, sometimes fitness influencers and sometimes even doctors, that one needs to do weights to build muscles because muscles support bone density in the long term. While doing that, there is a normal fear in a person that bad form or doing beyond capacity may injure. So how does one one tackle that balance?
Yes. One is the graded way. One should go in a graded way, and one should able to identify one's limit. I have come across many young patients. They have been doing heavy weights in the gym, and they are definitely damaging their elbows and shoulders, and they are in a lot of trouble. And I just asked them why, how it happened. They said my gym instructor told me you are capable and all those things, which I said is something one has to consider it that way. I think if a class for the gym instructors can be taken by somebody, it will help in preventing damage in a much better way. Or the other is uh, that the other is the users. I mean the young people who are using them, and to tell them always teach them always go in a very graded way. Don't overuse them. The simple law is Young's law of modularity, which if the stress is too much, then the muscle or tendon is going to break. Yeah.
Okay.
There is a limit to elasticity. I mean, you can't expect a BMI of say 20 to lift 40-50 kgs in the very beginning.
Okay. So, but sir, then is the theory correct that focusing on muscle strength training benefits bones also
Yes.
as you
If
grow?
proper instruction is given, if definitely in the younger age, the stress is on the muscle development, and the it directly helps to maintain the bone strength up to the old age.
So
In
another,
the
sorry, no, please go ahead, sir. Please.
in the younger age, if you are physically active, I mean carrying on with your sports activity, and I mean proper gymming, definitely it keeps your joints and muscles and mind young in the long run also.
And sir, another question, which I think fitness influencer industry. So we keep reading when we talk to doctors, they maintain they give like 0.8 to 1.2 gram of protein body weight is sufficient. If somebody is athletic training, 1.2 to 1.5. But we keep reading, okay, now sometimes they push to 2 gram per body weight. So what is your viewpoint on these? Sometimes because overuse of protein can also lead to some complication somewhere.
Yes, overuse is definitely going to damage your kidneys. Plus, you have to be careful they don't have anabolic steroids added, and more protein will definitely can cause even kidney shock also. I mean, they can permanently damage the kidney. So one has to be careful, and I mean the gym people, or they can talk to the nutritionist or a proper dietitian to properly guided. And one should be also careful the whether they are taking whey protein, or the wheat protein, or barley protein, or other proteins, milk proteins. And now we have off the shelf directly amino acids available, which directly are the main building block of the proteins. So they should be taken under proper guidance. If proper guidance is necessary, I mean your and the patient GP or the some nutritionist or the dietitian can properly guide it. I think it will be a better way. I always tell them you consult our dietitian. She will guide you how much protein should be taken, and depending on your body weight, and depending on the your gym routine or exercise routine.
But the problem, sir, people don't
Follow
consult
it.
doctors around this. They listen to influencers who
So
are.
the social now we have social media, and I think these message should be there from these. I mean, young doctors we have today. They should be active on the social media, no, and
Yes.
they can. I think their social media has a lot of influence on the younger people, because all most of them come well educated from the Google and from the YouTube, and I sometimes get frustrated. No, that way, if somebody is guiding them on the social media, I think our young doctors can also guide them on the social media in a better way,
Yes,
in a
sir.
proper way.
Yes, sir. And sir, now we have a question from Dr. Stephen Kope. He is from Cameroon. He's a general surgeon. So his
Yes.
question is there an age limit to use PRP injection for joint pain in children?
No, there is no limit, no age limit. You can give in up to 60, 70 normally, no problem. The only thing in PRP, you have to take around 14, 15 ml of blood. In GFC, you have to take 10 ml of blood. And we are able to get around 5 ml of uh, the serum plasma, which is good for injection.
No, sir. Now coming back to like for normal young adults, like you're prescribed that don't push yourself, and it should be graded response. Now we see in the African continent, I mean, they excel in some sports. Like if we talk about Kenya and Ethiopia,
Mm.
they are
Mm.
known for
They're
being
excellent,
marathoners and breaking world
excellent
records
marathon
in
runners.
marathons.
Yes, yes,
But sir,
yes.
and with your extensive experience in sports, like in India, we have cricket and fast bowlers, means definitely injuries in the career. So
Mhm.
how do doctors, like if they are treating and consulting athletes, and athletes have to push
Mhm.
their limits. So how do they
Mhm.
approach it, sir? I mean, you being a sports medicine injuries doctor, you must have dealt with this dilemma multiple
Mhm.
times.
I think, see, because they are in the competitive game, sports, they have to perform. That I agree. But see, uh, their actions, we will not be the right persons to guide them how they can improve their actions so that they achieve minimum of injuries or minimum of sprains or strains. I think they have other physiotherapists, sports physiotherapists, which can guide them in a better way. The only thing is certain precautions are must. I mean, uh, well-padded shoes for marathon runners, or which and hydration is very important, and intake of protein and vitamin D, calcium, and all those things are very important for these people because it is a I think it's a different industry with physiotherapists and with the nutritionists and with the sports person doctors. So we everybody has a role, and to once we come into play when the injury is there, right?
Okay.
So we are not very much there, but definitely when the injury is there, then we try to uh, make them recover in the earliest possible way with our physiotherapist, so they are back to the sports as early as possible.
So now we have a question from Dr. William Gadaga. Can PRP and steroid injection be used concurrently?
No, a steroid I only give when the pain is there. Initially, you give steroid, not concurrently. Regenerative therapies, PRP, are given when it has become chronic. You have to label it the problem called chronic, and there is no inflammation. That you have to clear it, and you can't give together because the role of steroid is to reduce the inflammation. It is like at other NSAIDs, whereas PRP is a regeneration. It is for regeneration. Once you have labeled that it is not going to heal with the in its normal healing period, then you shift to PRP, not together.
Now, Dr. Philomena, just making sure that Dr. Rakesh had prescribed the treatment approach to the patient case you discussed. Later on, once we have access to the transcript, we will extract the relevant section from there and share it with you. Additionally, what you can do is share the reports with us on the work group and your note around the patient with all the relevant history, and we will share it with Dr. Rakesh for his review. I mean, probably in the next couple of days when sir gets time, maybe he can go through it and share something with you how to approach.
Okay, thank you.
And
Thank you.
if there are no more questions, so I think we can conclude the session. Sir, thanks a lot. I know how busy your schedule is, And thanks a lot for taking time this Sunday evening. And also
Thank
thanks for, committing your slot to this Jivo Connect Clinic Drive, which acts as a bridge between the African doctor practitioner and the specialist input like you. And I think Dr. Stephen is one of those doctors who is here today. Uh, his patient consulted with you through that Connect Clinic Drive, and they got clarity around their
you.
condition. And thanks a lot, and thanks everybody who attended this masterclass. And about Connect Clinic Drive, please do not hesitate. The first thing is documenting the patient history, having the relevant reports. We will share it in advance with Dr. Rakesh Mahajan and provide a schedule to you so that your patient gets a joint clarity and the comfort that there's a doctor involved in their home country as well as a specialist from India, and they have access to the best possible medical advice possible on the planet. Thank you, sir. Thanks a lot for your time.
Thank you.
Always a
Thank you,
pleasure to
Madhu.
have you,
Thank
sir.
you, all the doctors, for your, lively session. And I enjoyed the evening, definitely. Good day.
Thank you, sir.